Thank you all for taking some time to be with me. And I think initially you may think, well, what does this have to do with anything? I know what I'm supposed to do. I know my guidelines. So why do I need to know this too? Well, I suspect that you always worry about what happens to your family and your friends when they go to the hospital or need to be imaged or undergo cancer treatment. So I think it's really important that we talk about this. I think that when we don't know what to do, we fall back on our ethical values, and it's important that we identify what those are and think about them from time to time. So I want to have a chance to talk with you all about what that means. And first of all, we have to have an understanding of what the language means, and then what they mean around the world. So in 2018, the ICRP formed Task Group 109, which is looking at and near completion with a draft document that is going to be out for public consultation. So that means all of you in Latin America and around the world can comment on what you like or don't like, or want to add references to your own to the document for our consideration. So we hope that will be happening by the end of the year or early in next year. So please look for that. The membership is on the slide in front of us, and you'll see that it is truly international. We have also some patient advocates that are trained through the WHO. The closest to Brazil we have is from Peru. What are the goals that we set forth in the task group? So I want to go through what we've done in the document and what we're trying to accomplish. Well, we want to clarify ethical aspects in the use of radiation technologies in medicine. And that can be very tricky because we all have different training, and we need to keep up with all those technologies. And we start with some basic concepts that were put forth in 2018 with the publication of 138. We use numbers for our publications. And that was quite a bit of work to look at the core values and procedural values associated with the system of radiological protection. What was new is to be very explicit and intentional about that. And these values are dignity, beneficence and non-maleficence, prudence and justice. And then procedural values are accountability, transparency, and inclusiveness. Inclusiveness is meant to be stakeholder involvement, particularly the patient and family when we're talking about medicine. So these shouldn't surprise you too much. They, however, vary a little bit when we compare it to those in biomedical ethical values. So the Beauchamp and Childress biomedical textbook, which is known internationally, uses core values of autonomy, non-maleficence, beneficence, and justice. Autonomy tracks very similarly to dignity, but autonomy gets at the need for patient self-determination, and we'll come back to that. Oops, I think I went backward instead of forward. So the task groups wanted to clarify ethical aspects in the use of radiation in medicine by focusing on radiological protection of patients. We determined out of scope being research-related exposures and occupational exposures. And there's a new task group 126, which is focusing on updating an older publication on research using radiation. The intended audience is mainly for radiological and medical professionals, but also for managers and administrators, vendors, regulatory authorities, and also for patients and families and the public. So here's how we deliberated over several years, and we included a WHO workshop that brought together a larger number of people to have discussions in determining how to merge medical values with radiological protection values. And we came up with paired core ethical values and some procedural values. So how do the core ethical values in publication 138 show forth in the 3 principles of justification, optimization, and limitation? And this is described in more detail in publication 138, which is available as free access, by the way. Once our publications are out for 2 years, they're free for anybody to look at. So I recommend that you do so. Let's start with beneficence and non-maleficence. We know that this is promoting or doing good and avoiding or minimizing doing harm. And this is reflected in the principle of justification and also the process of optimization for non-maleficence. We also have the core value of prudence, which is making informed decisions and carefully considering our choices without full knowledge of the consequences sometimes of the actions we take. For example, there may be a risk of cancer down the road, but we want to make a decision today to move forward with an imaging test. So prudence is part of our linear no threshold model, which is the basis of our radiological protection system. Now, the third core value is justice, and we think about that in terms of fairness in the distribution of both advantages and disadvantages of using the radiation technologies in medicine. So we want to make sure that the burdens and the benefits are evenly distributed and make sure that vulnerable patients are treated fairly. Finally, we have dignity, and dignity, as I said, is correlated with autonomy in medicine, and that means that we have unconditional respect for every person, irrespective of their personal attributes or their circumstances. Why do we have procedural values in addition to our core values? And these are considered global. Regardless of culture, the core values are agreed upon. Well, the procedural values allow us to implement those core values and to measure them. The accountability and transparency kind of track similarly. They allow us to make sure that those in charge of making decisions must answer for those decisions, good and bad, to all the stakeholders that are affected by the decisions. We know that that is not always true, but this is aspirational. Transparency or openness should occur when decisions and activities affect stakeholders, including society and the economy and the environment. And that includes a willingness to communicate about these decisions and activities, such as imaging procedures to the patient that are clear, accurate, timely, honest, and complete. And that means errors or side effects. In the medical field, it is implemented according to different procedures, and that means through education and training and informed consent of patients. Finally, inclusiveness is the involvement of all relevant parties in a shared decision-making process. And in medical facilities, we use the concept of ALARA to help keep patients and workers safe. So the task group decided that there was a need for some further interpretation of the core values and of some of the procedural values, and identified balancing the need for a limited number of further values to put forward with a need for more description, and settled on 5 more values. And these were solidarity, linking it with justice, solidarity meaning common good, as a mutual recognition and support, empathy, which relates to inclusiveness and is considered very important in medicine in order to understand a patient's perspective or a family's perspective in shared decision making. Honesty, and that is both a personal and a professional commitment to candid and truthful sharing of information. And I point out that this is bidirectional. It doesn't mean just the professional side or the radiological protection worker to be honest, or the facility where the imaging or therapy is being given, but it's also the patient and family that must be honest in the sharing of their history and problems in order to be treated in the optimal fashion. And then precaution links to prudence. They're very similar values, which takes measures to prevent or reduce risks for which we have no direct scientific evidence. So this is important when we're considering radiosensitive populations or vulnerable populations. Autonomy is a corollary of human dignity, and it relates to the, as I said before, the patient and ensuring that they are empowered to be a part of decision making. So further discussion on what we have tried to put forward in the contents of the document. We introduce core and procedural values, these added values included in the context of diagnostic radiology and radiation therapy. We want to increase familiarity of professionals with the ethical foundations of radiological protection. We want to integrate ethical considerations in everyday practice of medicine. And we want to show where it might be useful to employ these values with a series of scenarios. So I'll give you some examples of when they might be practical and useful. Sometimes there's a lack of scientific evidence about patient care. Yes, we have guidelines and we have evidence for when to treat common medical conditions, but there are certainly rare conditions where it may not be the case, or we may as an individual confront in a very unusual situation and we're not sure what to do. We may need to fall back on values. Another example is there may be disagreements, and they will happen between a patient or family member and us as providers or the care team. And we may need to employ an ethical consult or fall back on our values. And finally, there may be disagreement. Not sure what that is, that background noise. There may be disagreement within the care team. And then that's where it can be very useful to think about things and go through what our values are. I don't know if there's a way to mute that noise. So other things that we're trying to do is provide an evaluation method to analyze specific clinical situations from an ethical point of view and show how balancing various values allows a group of people or an individual to arrive at a solution for a patient and family on whether to use or not use radiation technologies. And I'll give you an example in a moment. Also, tabulating paired ethical values in a table for compliance or non-compliance with values in a specific short scenario can help elucidate why these values are important. And then provide teaching scenarios where clinical teams face ethical challenges can be used in undergraduate education and training, and then ongoing professional development throughout a career. We endorse this education and lifelong commitment to training in radiological protection in medicine for all professionals, and we endorse the support by facilities employing all of us in that environment to obtain that ethical training. And we provide some free programs and tools and references. We promote the use of professional codes of ethics and hospital ethical review committees when necessary. So the two books that we relied heavily on were the Beecham and Childress Principles of Biomedical Ethics. It's now in its 8th edition, most recently 2019 publication. And Beecham, who has a utilitarian outlook, and Childress, a deontologist outlook, defined a set of principles. Whoops. What I was trying to talk about was the documents that are the basis of the teaching of this really interesting case scenarios. And one is Beecham and Childress. If anyone wants more information, please contact me. They have been working in this field for over 50 years. And they really started this work when they realized that there was no medical ethics ground truth. There was no set principles. And so they defined this set of principles that suited both of their outlooks, although they were not exactly alike, without referring to a single theory of ethics. But all persons were committed to morality could agree. So that's a very interesting concept there. And that's the cover of the most recent edition on the bottom left of the slide. And there's also something interesting that I want to note, that biomedical ethics is really derived from an ethics of care, which is different from law, the ethics of the law. And it's a feminist perspective, and this is often overlooked. So you have to dig for it in Beecham and Childress. And I want to say this because as pediatric radiologists, we often think about the ethics of care, and in medicine, the ethics of care, where if you go outside of that and into the legal world, it's very much justice, and the kind of justice that is rather punitive. So I think maybe that's something we could talk about. Also, the teaching method is from the other cover textbook by Jim Malone, Friedel Zolzer, who's also on, both of them are on the task group on this document, and two others. And it's looking at the teaching method of looking at ethical value tables. So we revised it from their textbook from 2019. So this evaluation method provides a practical way for all professionals and patients and families, if they're interested, to consider the relevance of ethical perspectives from different cultures, different situations, and different beliefs. And we limited the set of paired values to 6 paired values, otherwise the table can get unwieldy. And we looked at, we call it compliance or non-compliance. And we used happy faces and unhappy faces. So smiley faces and unsmiley faces to attribute whether the description of the scenario, people were complying with the values or not complying, or were neutral, or it didn't apply. So the cases in the document can be both compliant and non-compliant for a value, and I'll show you an example. And there is, remember, no single right answer, but a balancing of values to be used in each situation. We provide 10 imaging procedure scenarios and 10 radiation therapy scenarios. These are all based on true cases, but they're simplified. We also provide, in addition to the table of definitions of terminology and how the core values came about for the two textbooks, we also provide sensitizing questions for people that want to do journal clubs or discussion groups on ethics, so that people can think about, have we reviewed this case critically? Have we discussed it thoroughly with the patient? So for example, if you take the core value, paired values of dignity and autonomy, and we review a quick definition in the dark blue as the value and respect that every person has and deserves regardless of his or her age, sex, health, social condition, ethnic origin, religion, etc., protected by the Universal Declaration of Human Rights, and we have a reference for it. We also say it's the capacity of individuals or groups to act freely, decide for themselves, and pursue a course of action in their lives. So we ask sensitizing questions around that. Have we discussed the role the patient wishes to take in deciding what kind of imaging or therapy they are going to be making? Have we respected patient confidentiality? And there are a number of other questions that we put forward for, consideration to be thinking about. Each of the paired values has similar such questions. All right, so here's a very simple imaging procedure scenario. Mrs. Mary Jane is a 39-year-old single mother. Oops, I've gotten it again. Single mother, a proud mother of Jack, her little 2-month-old baby. She has carefully planned to find in the next week a babysitter who will care for Jack. A PET study has been ordered for suspected vertebral osteomyelitis for Mary Jane. The radiopharmaceutical used is known to have low activity concentration in milk, and thus no interruption of breastfeeding is required. She is given this information and happy to receive it. However, after completing the examination, she received a leaflet with instructions to limit close direct contact with infants for 12 hours after the scan. The suggested approach is to extract milk and let another person feed the baby via a bottle. She is surprised and concerned since she is not prepared to pump her breast milk and does not have a person to take care of Jack. It is likely that had she been aware of these instructions prior to the exam, she would have declined the appointment or postponed it until she could find someone to take care of Jack. So this example shows the importance of addressing the needs of patients, not only with respect to recognized benefits and harms of an imaging procedure, but also with respect to the practicalities of their personal situations, their concerns, and their points of view. So let's look at the table with the paired values in the left-hand column, and then their compliance, our perceived compliance and non-compliance in this scenario. So for dignity and autonomy, we have good compliance for the patient, but we have some non-compliance in terms of understanding the living situation and asking questions in a structured way and understanding timing. So compliance with respect to beneficence and non-maleficence, again, we have two smiley faces because there's no doubt that this was a justified exam, and we have no information about non-compliance, so it's a neutral or dashed line there. For prudence and precaution, again, we have two smiley faces for the patient, that it was appropriate, and there's a neutral for that prudence precaution for the patient. For justice and solidarity, there's one unhappy face and non-compliance because the family environment wasn't taken into the consideration. And for transparency and accountability and empathy, there were two unhappy faces for both of those rows because of the, as we discussed on the prior slide, the importance of understanding the patient's situation and communicating. So I hope that's a very quick run through an example of a scenario, and certainly there could be some interesting discussion around all of that. So I wanted to make a few points about education and lifelong training in ethics and how it can be important, especially over the arc of your career with so many changes that can occur. First of all, societal values evolve. We know artificial intelligence is a part of our world now, and it could have a very important role in medical imaging and therapy. So ethics will play a very important role in understanding and interpreting the technology around us and explaining it to patients and each other. And same with genetics and radiosensitive populations, and also to continue to look at the privacy of healthcare records. We also understand that it's so important for training in informed consent for patients and for shared decision making. And Dr. Bernardo has done some interesting research in understanding how empathy can be taught and learned. And so one of our main points in our document is that every health professional should continuously strive to achieve it. That's a main point. And we also have found literature to support empathy improving patient outcomes. So there's been some interesting research that improves patient satisfaction, not surprising, but it also improves diagnostic accuracy and patient outcomes. We have tables, as I said before, on value descriptions for scenario assessment that help to bring back to the people doing this type of training, or just want to take a quick look and say, hey, how did we do? So this is just an example of some of the short definitions, but there are also longer descriptions in the early chapters of what these different values mean. Here's one more imaging procedure scenario in interventional radiology, where patients received higher doses than they should have. The hospital interventional radiology suite recently had to replace an X-ray tube. The vendor delivered and installed the tube 3 days later. The medical physicist, Dr. Russet, was contacted then to test the equipment and certify that it was safe for clinical use. However, he was working elsewhere and would not be available for 4 days. Dr. John Cinnamon, head of interventional radiology, did not view the situation as urgent, and he left calling the medical physicist until the last minute. Dr. Cinnamon was assured by the vendor's engineer that it would be all right to accept patients once the tube was replaced. So given the situation, he decided the procedures would start immediately, and 35 patients were imaged prior to the medical physicist, Dr. Russet's, quality control assessment. Upon testing, he found a filter missing, among other issues, leading to patients receiving between 2 and 10 times the doses higher than typical before the tube replacement. So 35 patients received significantly higher doses. Dr. Cinnamon was understandably upset, but decided the patients would not be told, as the information might worry them. The medical physicist, Dr. Russet, advised that there was an obligation to let the patients know and a duty to inform both the facility and the regulator. Dr. Cinnamon decided to refer the matter to the Radiation Safety Committee, scheduled to meet in 3 months. So if we look at the scenario in terms of the paired values in compliance and non-compliance, the main concern was Dr. Cinnamon, who was in charge, and his failure to look at really most of the paired values. He did provide access to the examinations in a timely way for these 35 patients. So he got 1 smiley for autonomy and dignity, and he got 1 smiley for inclusiveness to, or I guess the team did for trying to get the patient in, but otherwise it was 2 unhappy faces for all of the values. I guess that was the way the people who wrote this scenario rated it. And again, I think this would be a really good one for a small team to do this and then discuss it. So this is a small example of some of the scenarios, and I'll leave you with a quote from Lauriston Taylor, that radiation protection is not only a matter of science, it's a problem of philosophy and morality and the utmost wisdom. And hopefully we'll all keep learning. With that, I want to stop here and have some time for discussion amongst our group.